Welcome. Thank you all so much for joining us for the National Ovarian Cancer Coalition's 2024 Fall Online Wellness Symposium. Our second session this evening is Unlocking Answers, the Significance of Genetic and Biomarker Tumor Testing in Ovarian Cancer, with Patient Journeys Shared. I'd like to take a moment to sincerely thank our symposium sponsors who are dedicated to providing learning opportunities and programming for our teal community. Thank you so much, first and foremost, to Northwell Health and to our sponsors, GSK, AstraZeneca, Merck, Veristem, and Asai. My name is Stephanie Taylor, and I am the National Ovarian Cancer Coalition Senior Manager of Programs and Community Engagement. And we are very grateful tonight to have a wonderful panel assembled this evening to begin our discussion. So first and foremost, I would like to begin by introducing Dr. David-West, a gynecologic oncologist from Northwell Health, and then three inspiring survivors, Carrie, Gail, and Evelyn. So to begin with, Dr. David-West, can you please tell the audience a little bit about yourself tonight?
Yeah, hi. Thank you so much, Stephanie, for the introduction. Very happy to be here and so happy to see such a full room on the Zoom. As Stephanie mentioned, I'm Dr. Gizelka David-West. I'm a gynecologic oncologist with Northwell Health. I'm the director of GYN oncology at Northern Westchester Hospital. It's one of our Westchester hospitals. I also take care of patients at our Phelps Hospital, which is located in Tarrytown, also in Westchester. I did my residency at Mount Sinai in New York. My fellowship was at NYU, also in New York. And I've been in practice for several years, initially starting out at Westchester Medical Center, a major medical center here in Westchester, and then transitioned to basically build the GYN oncology program for Northwell in the Westchester region. Very excited to be here. I'm a mom of three boys. Also, another fun fact is I'm the lead singer of the band No Evidence of Disease, which is a GYN cancer advocacy band. So it's if any of you haven't heard of us, look us up. It's really awesome. We do shows all over the country. I've been with the band since 2019, but the band has been around for over a decade. All original music, really inspirational and uplifting stuff. It's a lot of fun. And so in line with my strong passion, we're advocacy and awareness band, and that's a big passion of mine, is to spread awareness, education to people affected with GYN cancers and those who just need to know more about it so that we can prevent the disease. So happy to be here.
Thank you very much, Dr. David-West, and we really are honored to have you as part of this discussion tonight. And thank you for the care and support that you give to your own patients and then now beyond. So thank you. So to begin, I would love to have the audience get to know Evelyn, Carrie, and Gail just a little bit more about you. Could you each share where you're from, a little bit about your family, and perhaps a glimpse into your life outside of cancer? And if you'd like to tell us how many years of survivorship you are celebrating, help us understand the person behind the journey. So to begin with, we are going to begin with Evelyn.
Hi, everyone. My name is Evelyn. First of all, I have to say I'm so excited about the NED celebrity, because I think at some point in my research, when I was first diagnosed, I came across the acronym of NED, and I do remember seeing something about a band. So that's amazing. I'm very excited about that. So I live in South Jersey, just outside of Philadelphia, but originally born and raised in New York, which is probably why I ended up gravitating towards Stephanie's group and being connected with many of the women in the Long Island chapter or the Northeast chapter. I'm 54 years old. I was diagnosed 2 years ago, so it's 2 years ago, I guess, is my survivorship, 2 years. I am a mom of two. I have a son who's 20, in his third year of college, in Boston, so away from home, which that was very difficult to have him away from home during this. And I have a 15-year-old daughter who just started high school. And then just a little bit about myself. I was always very active. I still try and be as active as I can be. Um, I actually, right before I was diagnosed, had gotten my health coaching certificate. So I was getting ready for my, as I call it, my encore career to help others. And, um, I was really focused on my health. So it was quite a surprise when I was diagnosed. But that also, I guess, has inspired me to share my story with other people once I was ready. And so, yeah, just glad to be a part of this evening and to share my story.
Hi, everyone. Carrie. I am from Long Island, New York. I am married. A mom of two. Um, I'm 59 years old, and I work in operations for a clinical trials laboratory here on Long Island. I've been doing that for about 15 years. I'm a passionate volunteer for NOCC for the past 7 or 8 years. I love that. And I am a 9-year ovarian cancer survivor.
Hi, I'm Gail. I live in the southwest suburbs of Chicago. I just turned 65 this year, big year. I've been married for 42 years. I have 2 daughters. My oldest is actually getting married on Saturday, so we're a little busy here. And my oldest lives near me. My youngest lives in Colorado, and she has my 17-month-old grandson, first and only grandchild so far. Things I like to do, I like to read, I like to do jigsaw puzzles, and I especially like to travel. I've been to Colorado a lot since she's had the baby, even before that, to see her. Nice place to visit, but I wish she were closer. I think that's it. I am a 7-year survivor.
Thank you, Gail. But exciting things to look forward to for this weekend. So we're very excited and happy for you. And to all of you, I would like to thank you for sharing glimpses into your lives. And we're very grateful to have each and every one of you here this evening. So as we start our discussion, I would like to mention a handout that we sent out before the program that I am going to be sharing in the chat, just in case anybody wants to reference it as a guide. It will guide our conversation this evening. And before we begin, I am going to ask you, Dr. David-West, could you please set the stage for our discussion tonight with a simple summary of why we commonly group these 2 types of testing together, genetic and biomarker tumor testing, and their roles in ovarian cancer?
Sure. So ovarian cancer treatment over this past decade, really, the landscape has changed dramatically. And in the last few years, there's been even more of a focus on genetics and finding more personalized and targeted treatment strategies. And so with genetic and biomarker testing, we're able to find mutations either that are inherited or that are at the level of the tumor that we can then target and treat so that we are then prolonging survivorship. We're prolonging the time people are living without this disease recurring, or prolonging the time people are living well with disease. And some of these targeted treatments have shown improvement in overall survival. And really, this is game changing for ovarian cancer, as majority of the time, this disease is diagnosed at advanced stage 3 or stage 4. So really a lot of emphasis on genetic testing with how we are treating this disease.
Thank you, Dr. David-West. And I know that you actually have a video that's provided by Northwell Health that we would like to share at this time. So my colleague Jennifer is going to share a video with our audience this evening.
Your DNA. DNA is the material that makes up your many genes. Genes have lots of jobs. Some genes protect your body from cancer. You have 2 copies of each gene, one from your mother and one from your father. As you grow and age, your cells must copy themselves countless times. Every time this happens, it has to copy all of your genes, which means copying 3 billion chemical letters close to perfectly. Sometimes mistakes happen during this copying. These mistakes are called mutations. This can happen in any of your genes. If it happens in one of the genes designed to prevent cancer, you still do not get cancer, since the second copy of your gene from the other parent continues to work. However, the mutation does get passed on. Only if, in another cell division, a mutation occurs in the second copy of the gene can cancer develop. In some cases, you are born with a mutation in a gene designed to prevent cancer. These mutations can be inherited from either your mother or your father. Even if you inherit a mutation in one of these genes, cancer does not develop. However, that mutation does continue to be passed on though. Because cancer only requires one further mutation in the remaining gene, people who are born with one of these mutations are at an increased risk of certain cancers compared to the general population. BRCA1 and BRCA2 are 2 genes that everyone has. They are particularly important in preventing ovarian, breast, pancreatic, and prostate cancers. The genetic test offered today will test for mutations in both of these genes. While BRCA1 and BRCA2 are the most common genes associated with hereditary ovarian cancer, other genes such as PALB2, TP53, and Lynch syndrome genes like MLH1 may play a role as well. The test you will be offered today looks at these and other genes known to be associated with ovarian and related cancers.
Approximately 15 to 20% of ovarian cancers are caused by an inherited gene mutation that can be detected with this test. Another 10 to 15% of ovarian cancers may be associated with a combination of inherited and environmental factors. The remaining 65 to 75% of
So Dr. David-West, can you just briefly explain to us a little bit about the video?
Yeah, so this is a video. It's just the very first 3 minutes of a video that we share with every new ovarian cancer patient. So we have a fast track genetic testing program so that we get this testing really kind of within weeks of their diagnosis. So we do what's called germline testing, which is testing to see if there is in the blood mutations that have been inherited that could be contributing to the disease. And then we also do tumor testing, which tests the tumor, the actual cells of the cancer, to see if there are mutations there. And this information then guides the treatment plan with either what we're doing upfront for treatment, or if we're doing maintenance treatment, or then treatment beyond the initial first line of therapy. And so I think that the video explained it really nicely in kind of describing the whole idea of our DNA and how these mutations occur. And I think the general concept is we have so many cells rapidly dividing and changing over time. And in cancer also, that's what it's doing on a daily basis. And each cycle, each replication, an accident or a mistake can occur. And that's what then creates these mutations that allow the cancer to either progress or recur. And then with these drugs that we now currently have, we're able to target these specific mutations, either the inherited or at the tumor level.
Okay, thank you very much. So again, just to reiterate for the audience, there are those that we inherit, which germline, and then those that are within the tumor itself, so they're somatic. Okay, thank you very much for clarifying that. And Dr. David-West, can you tell us also why is genetics testing so important for people with ovarian cancer?
So right now, in the last part of that video, it described that anywhere from 15 to 20% of ovarian cancer is from an inherited mutation. And then there was another 15% that's inherited or a combination of inherited and environmental factor. So we're looking at like 30% of a patient population that could be linked to some kind of inherited mutation. And so knowing this information then really guides the treatment. And so this is why really this current standard guideline from our governing bodies like ASCO, American Society of Cancer, the SGO, which is Society of GYN Oncology, and CCN, these all tell us and recommend that anybody with a personal history of ovarian cancer should have genetic testing really at the start of their journey. And then of course, we encourage testing of family members as well if they're willing and interested. But it really helps plan out the course of the disease and really allows us to give people information about kind of prognostic factors, right? There's various degrees of benefit with certain mutations and certain drugs that we have. So it really it very much informs the treatment of the disease.
Thank you, Dr. David-West. Could you also share with us this evening, why is it that when an individual does do the genetic testing, how it helps guide their treatment and decision-making process? Like, what should they be speaking to their doctor about when they are getting these tests done?
I'll give an example. I think sometimes it's easier to speak to examples. So let's say you have a patient who has genetic testing done. It came to my office, they're diagnosed with ovarian cancer. We have shared this video, we do the testing, and it shows that they are BRCA1 positive. This then, and they are stage 3 disease. Knowing this information up front, number one, we can then tell the patient that based on data, based on research that we know, BRCA mutation carriers tend to have a more favorable prognosis or favorable response to treatment, longer term survival. And then it also tells us that we can utilize certain drugs. There's the PARP inhibitors. A lot of you on the call might be familiar with that, maybe are on PARP inhibitors. It's a drug that we can use as a maintenance therapy drug. And again, the data that we have has shown a profound benefit in the BRCA mutation carriers, also shows benefit in non-mutation carriers, but having this information and knowing the information up front really guides the discussion and the conversations about at what point these drugs can be introduced during the treatment course. For another example would be when we test the tumor. If the tumor testing is done and there's, let's say, an HRD mutation, a homologous recombination deficiency, which again, some of you might know about that, that also then guides the treatment and tells us about utilization of PARP inhibitors or not. And so when you are having these tests done, these are the questions you should ask are, how is this going to benefit me, or why is this information important? And pretty much everything I've said is what would be explained to you. I think also knowing this information then allows you to speak with your family and inform them that there's a genetic mutation, something that was inherited. You could be at risk, and so it's important to then offer that information, and your family members can make decisions on if they want to get testing themselves. Finally, having a BRCA mutation puts you at risk for other cancers, right? And so then knowing what heightened screening you need for those cancers is important, and plugging you in with the appropriate team members and doctors to help you through those heightened screening also is very beneficial.
Yeah, so can you also share with our audience this evening, how is the testing actually done? What is the process when somebody goes to get genetic testing?
Sure. So there are a couple ways. Like there's a saliva test, there's a blood test. That's the two ways you can do it in the comfort of your own home, by doing like a virtual visit with your doctor or with a genetic counselor, let's say, and they ship you the kit. You do a saliva sample and it gets mailed off, and you get the test in a couple weeks. If it's a blood draw, you're in the lab and the blood is drawn. And then again, results are reported. I think a really important piece to genetic testing is not just the test alone, but the genetics counselor. I think there might be doctor's offices that may offer the testing and say, oh, I can send genetic panel for you. And then they'll get the results and just kind of hand it to you and say, oh, here's the results, you're positive or you're negative. But then that's kind of it. Whereas a genetics counselor really, they are the ones that will sit with you for an hour or longer and really go through not just the test was positive or negative, but what the implications of that are. So you may have a negative testing, but let's say your family history is very strong. There's ovarian cancer, there's breast cancer, but then there's no mutation. That still puts you at a higher percentage risk for that disease because maybe there's a gene within your family we haven't found yet. And so the genetics counselors are so critical in explaining that and dissecting that information. So you can walk away knowing, okay, my testing was negative, but I'm still high risk because of X, Y, and Z factor. Or you go in, okay, my testing is positive. What does that really mean? What are my risk percentages for each cancer that's associated with this gene? And the genetic counselors are so good at that. And they spend so much time with you more than the doctors would. And so I think it's a key part of the testing. So if you ever do get tested, ask to also have a consultation with a counselor because they're the ones who are really going to break everything down for you.
But again, you can have your genetic testing done through a blood draw, through a saliva test. So important. And we're going to talk about this a little further in our discussion this evening, also about the significant role that genetic counselors have played. And in your opinion, again, for those that are on our call this evening, patients should consider getting testing done as soon as they are diagnosed?
Yes, I would definitely recommend that. I think the sooner you know, the earlier you know, it just informs the treatment. There are clinical trials that have looked at using PARP inhibitors upfront for treatment of advanced disease in combination with a chemotherapy, not just as a maintenance. And so it may open up that door of an opportunity if you wanted to pursue a clinical trial, for example. And then also it just allows you to have information up front to understand what your disease course or treatment course would look like. And so I think it's, in my opinion, and I think the rest of my colleagues would agree that it's essential to the treatment planning.
Thank you so much for sharing that. So Carrie, now we're going to turn to you. Can you please share with us how genetic testing impacted your journey?
So I was originally diagnosed in 2015 with endometrioid and serous ovarian cancer. I was stage 3C. My genetic testing indicated that I was actually both germline and tumor, BRCA1 and BRCA2 positive. And as Dr. David-West said earlier, my oncologist indicated that this was positive. This was a positive thing because that I was very likely to respond well to treatments. So I started chemo and I went through 4 months of chemo. And then in 2017, I was diagnosed with a recurrence of ovarian cancer on my spleen. So after additional rounds of chemotherapy, I started on a PARP inhibitor. Rubraca was the one that I was on, and I was on that for 26 months. So I think all of that, the way that my treatment went, I think was all due to my history and my genetic testing. Additionally, because of all of that, I made the decision after much encouragement from my oncology team to have a double mastectomy in 2020. So I did that as preventative measure. And then now I'm not on any treatment. I've been NED since 2017, and my plan now is I go once a year to my oncologist where I get the CA-125 test. It's a good marker for me. It always has been. And I tend to get CT scans every couple of years at this point. And really, I'm just kind of following that and always looking for more information about my risk for other cancers, especially pancreatic cancer is the one that I'm kind of making sure that I stay on top of. And I've seen a surgical oncologist to follow up, to keep following up on that for my future.
Harry, you've made some really difficult decisions for yourself to try to achieve better health outcomes for you after you went through your challenges of your diagnosis. That's really remarkable. And I thank you so much for sharing your personal experience. And you really are the epitome of strength. So thank you for that. And we're so grateful that you have been doing so well. So, Gail, I would love for you now if you would be willing to share a little bit about yourself and how genetic testing impacted your journey. Oh, Gail, you're on mute. It's okay.
So in my case, my family has a very strong history of breast cancer. My mom, my aunt, my sister, all my first cousins on my mom's side, even my dad had it. So I was very proactive in getting the mammograms and the breast MRIs. And then after my sister was diagnosed, she was diagnosed in 2015, we went for genetic testing because at that point it was recommended. No one in my family has the BRCA genes. I had a significant variance in what's called the CHEK2 gene. That was what my genetic testing showed. Then in 2017, I was diagnosed with stage 3C primary peritoneal cancer. At that point, I was put on the chemos and all that. For me, the way my body works, it kind of likes the treatment for a little while and then it stops working. So over these past 7 years, I've kind of been on I've been on chemos, immunotherapy. I even had radiation once. At one point, I was put on a PARP inhibitor, the Rubraca. I had tried Lynparza before that, and that didn't really work that well. Lynparza was the first thing that, for me, and even though I don't have the BRCA genes, it worked for me for over a year. And that's kind of was the longest that I have been on something. I've never been NED, like I think I said earlier. Yeah, so that's where I'm at right now.
Yeah, you are really an inspiration, and to use your voice to help other people better understand the impact of genetics on their journey as you're enduring your continuous treatment is really a gift to each of us. So thank you so much for being so forthcoming and honest. And as I said, your resilience is really inspiring to everybody. So Evelyn, I'd love to turn to you at this moment. I know your experience was a bit different. Could you share with us what it was like for you at the time of your diagnosis and whether genetic testing showed any mutations?
So I didn't have any family history of cancers. So I wasn't really concerned. I mean, my mom had I've gotten different faces when I say this, but my mom was diagnosed she was over 55 years old, and she was diagnosed with stage 0 endometrial. They did not, and even when I spoke to the genetic counselor, they didn't connect it with me because of the history on, when you look at the immediate family on both my mom and dad's side and talking about their age of any health issues overall. We sort of created a tree, I suppose, or some sort of genetic documentation. So anyway, so I was diagnosed in the ER, and I was diagnosed with high grade serous, and stage 4. That was in October of 2022. And so my treatment plan was this 3 rounds of chemo, surgery, and then at 3 rounds, I ended up having 4 rounds of chemo because they wanted to see a nodule decrease in size because couldn't quite reach it. So I did 4 rounds, had the midline incision, and then did another 3. So I did a total of 7. Apparently what I was told was, since I was tolerating the chemo well, and they would monitor that 3 rounds post surgery, what led to better outcomes. So I was like, sure, why not? I was doing okay with everything. And then I was NED by May of 2023. But that's when, so I'd done the genetic counseling, and that it was through a blood draw, genetic testing in the beginning of my journey. After the surgery, I feel like this information came in a little bit later, but after my surgery, which was midway through, I had the tumor testing, and the tumor testing showed that I was HRD positive. So and in my head, I don't know if this is the right way to think about it, but in my head, I think about it as I have stubborn cancer cells. Like they just need a little zap. So they started me on a PARP. That PARP is Lynparza. So I started that in June of 2023. So I've been on it for a little bit over a year. I have my CT scans every 3 months. I have blood work every like 6 weeks, about 6 weeks. And I'll be on Lynparza until June of 2025, so 2 years in total.
Thank you, Evelyn, for sharing that. I appreciate you mentioning the point about the tumor testing, which we're going to get to a little bit later in our discussion, but I really appreciate discussion. Again, Dr. David-West, you already touched upon this, but could you reiterate again, are there specific treatments that work better for people with different types of genetic mutations, such as the PARP inhibitors?
Yes, of course. So right now, a lot of the data and the research we have focuses on PARP inhibitors. There's several studies, several different types of PARP inhibitors. We've heard Lynparza, I heard Rubraca, and niraparib is the third one. So right now, the most current data from the SOLO trial and the PRIMA trial are looking at Lynparza or olaparib, and then Zejula or niraparib. So those are really the two that we're primarily using currently to date, and they've broken them down to basically BRCA positive germline, or germline meaning inherited BRCA negative, but HRD somatic level, HRD positive. It's at the tumor level, or sometimes the tumor can actually have the BRCA gene on it, right? The BRCA mutation, not just HRD. So really, the most favorable responses to PARP inhibitors have been in the BRCA positive inherited, BRCA positive tumor somatic, or then the HRD positive tumor test. When the studies on olaparib really just focused on the BRCA mutation carriers and the HRD, whereas the niraparib study was that one study that really showed us what does this drug do for people who are wild type, meaning they have no mutations, that everything is negative. And that study did show, compared to placebo, compared to like a sugar pill, niraparib still did improve progression-free survival for people who were totally negative. And so it became a new standard of care to offer niraparib to all comers, to say, you know, you're diagnosed with ovarian cancer, you've had all your upfront treatment, now here's this maintenance drug you can take for 2 years that shows an improvement in progression-free survival. Most current update on that study with niraparib describes that there didn't see an overall survival advantage as yet. I think it's been looked at for about 3-4 years now. They didn't see an overall survival advantage, but still, I think the progression-free survival advantage held on. So again, that's living as the progression-free is how long you live without the cancer coming back. And so that they found that all comers, negative or positive, still had some benefit. I think the argument some people give is like, oh, we're giving niraparib to everybody, so why bother testing anything? I think my counter argument to that is these drugs are not without risk, right? Any drug we give, any medication has risk benefit. There's going to be side effects, toxicities, and it's really about how you want to live your life and what you're going to endure and what you're not going to endure. And so for some people, if they know that they have a mutation that's positive and they know that the data shows a much more profound advantage when the mutations are there, they're more inclined to take the pill. When they're negative and there's no mutations and there's a little bit of a benefit, but it's kind of maybe not so great, they're kind of like, well, you know what, I'll take my chances because I don't want to have these side effects. I don't want to live on this drug when it may not really help me as much as it would if I had a mutation. And so I think it really helps inform the decision making, that shared decision making that we have with our patients. And so I think it's still so important to have that testing to really understand the disease and what these drugs are and the benefits and the risks.
Thank you. You bring up such a great point. It's about quality of life, risk versus benefit. And so I really appreciate you clarifying that for everybody this evening. So Carrie and Gail, you both are mothers of 2 daughters. How did you approach this important discussion about obviously you had to first share that you had cancer, but then on top of that, you then had to share that you had a genetic mutation. How did you approach that conversation with your 2 daughters? Gail, I'd love to start with you first, please.
Well, in my case, because of that breast cancer history, I mean, we had talked about cancer a lot, so it wasn't like a taboo subject or anything like that. So when I got tested, then my youngest, she was still in college locally, and so she had gotten tested as well. My oldest was not at that point. She didn't have good insurance at the time. I was a little worried about that. So she actually didn't get tested until 2018. So my youngest has no mutations. My older daughter has the same mutation that I have, the CHEK2 gene. So when I was diagnosed, then she saw my doctor, and then she gets monitored by her. She goes every 6 months for a CA-125, and she has annual ultrasounds done so they can basically keep on top of it. I was told by my doctor actually that both of them, it should probably at least 10 years before I got diagnosed, which was at 57, have preventative surgery to kind of, because of all this in our family, to lessen their chances of getting cancer. Yeah, so it wasn't a difficult decision in our house because of all of the history, and
Great.
and they're willing to take necessary steps to kind of prevent them from going through what their aunts and I went through. So
Thank you, Gail, for sharing that. And Carrie, your situation was a little different because it kind of opened up a Pandora's box for your family. So can you share what it was like for you to have this discussion with your girls?
It was challenging at first. My younger one was 14 when I was diagnosed, and my older one was 18. So, but I think my older daughter, from my younger one, she was young. She was young. She kind of her reaction was definitely different. My older one, though, was very interested. She wanted to know a lot of information, and she listened, and she asked a lot of questions. And she asked my oncologist direct questions when I don't. Everybody has a different journey. I happen to be in the hospital a lot for my first 6 months after I was diagnosed. So there were lots of opportunities for my family to meet my oncologist. We were, lucky that way. And they talked, the 2 of them, my oncologist and my daughter, talked a lot. And she really encouraged my daughter to get tested as soon as possible. And I don't think it was even a year later that my daughter got tested, and my older one. And unfortunately, she is BRCA1 positive. So as I continued on my journey, my oncologist suggested, my daughter actually wound up moving to California a few years ago, and my oncologist had a colleague out there who was doing a surveillance program. So she recommended that my daughter get involved with that, which she did. She has since moved to Los Angeles, so she moved to UCLA Health is where she is now. And so when they started with the surveillance, when she first got accepted into that program, they had, they had me send my my results and a lot of other information from our family. Similar to Gail, we have a lot of mainly breast cancer in our family, going back at least one generation. Actually at least two generations, and just very, lots of cousins and aunts and grandmother and all that. So and similar to Gail, they're recommending preventative options for her, and she's making decisions. She's 29 years old now, so she's making decisions now, and in fact has decided already that she would like to have her breasts removed. She's probably going to do that in early 2025. It's rough, it's not easy sometimes, these discussions. I think it's emotional. I know that I feel a lot of emotion about it. I wish she didn't have to do this, but she tells me that she feels really lucky because she may not have to go through what I went through. And now I need the tissues.
Okay, you can take a moment for those tissues, because this is a lot and it is a challenging conversation to have. And all of your daughters have shown bravery in having testing done. And these decisions, whether it's having the testing done or having the prophylactic surgeries, are not entered into lightly. And Gail, you demonstrated a very important fact and shared with the audience. You have two daughters, one tested positive, one tested negative. So again, going back to the video that Dr. David-West showed at the beginning, if you carry a mutation, it does not mean that everybody down the family line is going to carry that mutation. So I think that's something really important that we stress. And the fact that both sets of girls, for Carrie and Gail, are also seeking the guidance of surveillance programs after speaking with genetic counselors. So Dr. David-West, can you reiterate one more time, reinforce to the audience how important it is to go and speak to a genetic counselor to understand what this means as it cascades generations?
It's so important. Like I said, they have so much more time. At my practice in Northwell in Westchester, we have Dr. Noah Koff, he's world-renowned geneticist. He's an OB/GYN by training, but went and did genetics fellowship and genetic medicine. He spends, and I'm not even joking, like 3 hours with people who are newly diagnosed with BRCA. Like, I've had patients come to see me and they said they had to rush him because they didn't want to miss my appointment. But he's so dedicated, so committed. He's got an incredible counseling team that spends the same amount of time. And this is time that, again, as much as I want to spend hours with my patients, I just can't. And so I utilize these resources that we have at our cancer center and really encourage patients to go speak with them, hear all the details, understand how this really affects you, and they can really give you outlines and timelines or percentages as best as they can. Nobody has a crystal ball, right? Like, we can't predict the future, but they can give you, to the best of their knowledge, based on the data, based on the testing that we have to date and the percentages, and they really can guide you. They're so well educated and so informed that I think it's just imperative and critical to this whole process. You don't ever want to just walk away with a piece of paper that says you're BRCA positive, BRCA negative, without having a robust conversation with a genetics counselor.
Difficult journey to navigate, but there are professionals out there to help guide you. And Carrie and Gail, you've given your daughters knowledge that will help guide their future paths for healthcare. And that's so incredibly important. And most importantly, you're showing them what resilience means. And that is a gift in and of itself. So we spent a lot of time on genetics, but now I'd like us to turn the page a little bit. Dr. David-West, can we turn our attention, you touched upon it a little bit earlier, but biomarker testing. Could you explain again biomarker testing and what role it can play in treatment plans in the simplest terms possible?
Yeah, so simple. I like to think that I do explain things simply. I think it's a little bit of a superpower. um, so really biomarker testing or tumor testing, if you just think about it, it's not your blood, it's not what's circulating in your bloodstream, it's what's at the tumor level. It's literally now taking that tumor that we removed and looking at its genetics. Because again, cancer cells are doing what our DNA does. They're replicating, turnover, recycling themselves, duplicating themselves over and over and over at a super fast rate. And so they can make mistakes and they can make errors, and these mutations can pop up. And so there was a comment in the chat about, oh, should my tumor get tested again if I was diagnosed 3 years ago and I had a recurrence? The general answer is yes, if it is feasible to obtain a biopsy, right? So if there has been a recurrence and it's an accessible area to biopsy, our practice is to obtain a tissue biopsy so that we can repeat the genetic testing, because as I mentioned, cancer cells are constantly rapidly dividing and doing all sorts of things, and those errors are going to happen. And we have newer and newer drugs coming out every few months, few years. We're having a lot of drugs getting fast-tracked to be offered to eligible patients. And so if there is a new mutation, we can find it and we can target it. And so this is now going beyond that inherited, because the inherited stuff doesn't change. That's it. Like, you're born with it, you have it. That's not changing every year. What might change in the genetic testing is just how we classify the genes. And some people may have a BRCA that's a variant of undetermined significance. Some of you might have heard of that term before. That maybe get reclassified after, because the Human Genome Project are constantly reanalyzing it and reviewing all these genes that we found. And that variant of undetermined significance can be reclassified as a totally benign mutation, or can be reclassified as a pathologic. So that's something that could potentially change, but your DNA, your makeup doesn't change over time, but the tumor does. And so that testing at that tumor level really can inform the treatment that you could potentially get over time.
Okay, thank you so much for clarifying that. So should all patients undergo biomarker testing?
So I would say yes, and this is becoming a little bit more universal. There are different companies that do this, Myriad, Foundation One, I think Natera. There's a variety of companies depending on your cancer center or your oncologist office is what they use. But yes, really at the onset of diagnosis, and then with each recurrence, if it's feasible, I would say yes, anybody with ovarian cancer should have some tumor testing or biomarker testing.
So can we discuss some specific biomarkers? You touched on HRD, and a lot of people may have heard the term or abbreviation HRD. Evelyn, you actually mentioned it earlier yourself that you tested positive. But can you reiterate to the audience tonight, what does it stand for, and what do we need to know about it if somebody is HRD positive?
Right, so it stands for homologous recombinant deficiency. So it's, again, another type of, I think, Evelyn, you said it there, the tumor cells need a little bit of a kick, a little boost.
If they're stubborn, is what I say.
They're stubborn, yeah, sorry, they said like they're stubborn, they just need like a little bit of a nudge. So I like to consider these a BRCA-like mutation, because they kind of follow that same pathway where it's a breakdown in a process that's supposed to help prevent the cancer from forming at that tumor level, and it's just not working well. And so it's very BRCA-like because it responds to the PARP, right? So that's where a lot of the research started looking at it and said, oh, it kind of behaves in the same way as that BRCA mutation, but at this tumor level. And what's been found is that about 50% or so of high-grade serous ovarian cancers will have this, be HRD positive. There was a question in the chat about if you're germline negative, what's the percentage that you would be HRD positive? And that's variable, maybe 20 to 30% of those patients who are germline negative may end up with an HRD positive tumor. I think it just depends on what studies you look at. But it's worth testing, right? Because Somebody who's germline negative, you don't want to stop there. Let's test a tumor. Just like in Evelyn's story, she ended up revealing that the tumor was HRD positive, and she became a candidate for more reason to kind of advocate for the PARP inhibitor in her case, as opposed to if everything was negative.
Dr. David-West reiterated how you were on the PARP inhibitor. Before you had HRD testing, did you ever hear of it before?
No, I was all about BRCA. Like that was, at the beginning, that's all you heard about. And, it was in the news. Like I knew about BRCA well before I was diagnosed with cancer. So yeah, HRD, I had no idea what they were talking about. I had to do all my research.
Yeah.
It's like learning a whole new vocabulary for patients right now, Dr. David-West. We also hear
us too.
HER2 positive, which used to be very prominent in the world of breast cancer, still is. How does that impact the world of ovarian cancer?
Oh, this is really groundbreaking stuff right now with HER2 in ovarian and in endometrial cancer. I mean, we're all over it. Our last national conference, there were so many studies looking at these biologic drugs called antibody drug conjugates that target the HER2 receptor. And so even in better ways than like the traditional antibody drugs that we started with, trastuzumab or Herceptin is maybe something that people might be familiar with if they know somebody with breast cancer or you've had breast cancer yourself. That was the traditional target, but now we're creating these drugs that are really showing a more profound response when that HRD is present. When the HER2 mutation is present. And so again, this is something that's being tested for at the tumor level. And then finally, I think one other one is the folate alpha receptor mutation, also a new drug target that we found that's really showing a lot of promise.
Thank you for clarifying that for us. And also with all these different terminologies for patients, what advice would you give to a patient who's hearing this and they're a little confused? Going back to their doctor, talking to their nurse practitioner, physician, who should they seek the guidance from instead of Dr. Google?
Yes, like Google, we all use it. I'm not going to tell anybody to not Google anything. You do it at your discretion, or as much or as little as you need to. I would say, you want to find reputable sources. So Foundation for Women's Cancer is actually, it's an excellent resource. It's curated by a GYN oncologist like myself, all through the Society of GYN Oncology. And so I think that's one of the most reliable sources if you were going to look for any information. They're on website, on social media, etc. So I think that's a great place to start if you just kind of want to learn on your own. Speaking to your oncologist, of course, ask as many questions as you can, or if there's a nurse practitioner that works alongside your oncologist, definitely speak with them too. They're extremely knowledgeable and they can give you more reading material or just really kind of have a conversation that breaks it down a little bit better for you so you can really understand. I think just to keep it simple is what we're trying to do with all this testing is to see how we can better improve your survival or improve your outcomes. Is it at an inherited level because you have an inherited mutation, or is it at the tumor level? Is cancer that we've removed, but could there be microscopic versions of it that are floating around that have this mutation? Can we then target it to prevent the disease from recurring? And then treat it kind of like as a chronic disease and have a long-term therapy that you can take that, maintains the response that you achieved from the onset.
So Gail, you are living with your ovarian cancer as a chronic illness, and you are doing very well right now. So could you please take a few moments to share the most recent treatment plan that you are on? And I think it will give a lot of insight and hope to our audience tonight.
So while I was on the Rubraca, the Elahere was approved for use. So not even asking me. My doctor always just sends out my stuff to be tested to see if I'm eligible for the next new thing because of the way my body stops reacting to old things. So I was actually 100% positive for the folate receptor. So after the Rubraca stopped working, I started Elahere. That was a year ago, a little over a year ago. So I've had 15 Elahere treatments. After the first 2, I did get pneumonitis. Everybody talks about the eyes. I didn't know anything. I mean, you read it, but you don't kind of pay attention because everybody's focused on the eye issues you could possibly get. But I actually did get the pneumonitis. So then I was referred to a pulmonologist, of course, because she's looking at one thing. She wanted me to just stop and never go back on Elahere, but it was working for me. So I'm like, I don't think my oncologist is going to agree with you there. And she didn't. So she said, let's try and clear it up and then go from there. So I was on steroids for a little bit until it cleared up. And then the pulmonologist kept me on a low dose steroid. So I've been on a low dose steroid since the 3rd treatment and haven't had any more problems with that. So a lot of times, there are ways to work around some of the side effects. And if the doctors work together, I think they can usually figure it out. So the other thing I want to mention is that because I need so many different treatments, I was told that, if I had to specifically rely on the original like chemo, my body probably would not be able to handle it. So because of all of the different targeted therapies and different things that are not quite as bad for you on your body, I've been able to, like I say, survive for the last 7 years without ever really being an NED. There's always something there, but they're kind of controlling it. And that's what our goal is right now, to just kind of control it so it doesn't keep growing. Yeah, so, and I'm feeling good on this treatment now.
It is really remarkable that your healthcare team was able to identify a targeted treatment that is new because of the biomarker testing and folate receptor positive, alpha positive. Like, that is really remarkable, Gal. And also for them to work together with your other healthcare practitioners to find a way to keep you on the medication, and to find ways to handle those side effects that you're healing. That is a great team effort. And we're so grateful for that for you as you go into this weekend and are there to be there for your daughter's wedding and celebrate a milestone. So grateful for that for you, Gail.
Thank you.
Dr. David-West, this is a very difficult topic to understand, the whole biomarker testing. Is there anything else that you would like to share about it to help people just gain a little bit more insight or about their different treatment options that are a result of this nuance of testing?
Yeah, no, it is a big topic, but I think we broke it down pretty well tonight, and I think the handout that you guys have in the chat and that people can save is very informative because it gives picture diagrams, and I think that helps a lot when you're just trying to understand something. Pictures, speak 1,000 words, and I think it's a better way to sometimes understand things. I think the big take-home messages here are that there are options. I think this cancer has come a long way from when I started my training in med school, residency, through now to practicing for almost over a decade now. It really it just tells us that there's so many options and so many targeted therapies, right? So that we can allow people to live well with the disease or live without the disease for as long as possible. So I encourage you to advocate for yourself. If you haven't had the testing done and they're not talking about it, ask for it. Say, can I ask for the testing, inquire about what other options you have, just so that you can have the best for yourself and the best for your survival.
Thank you so much for sharing that and for really sharing your expertise this evening. It has been extremely helpful. I know we have some questions in the chat that you've already covered, but before we get to some of the others, Carrie and Gail, is there anything that you would like to say to to the individuals in our audience tonight who may have just discovered that they do have a genetic mutation? What advice would you give them? Carrie?
I would just say to find out, I think attending this was great. This is a lot more information in 1 hour than I was able to get at the time in lots of looking around and searching. You know, I feel like it can be overwhelming at first. It was for me, but you know, take a deep breath, knowledge is power, and find out what you can, and it lets you make the best decisions not only for yourself and your health but for your family as well. And encourage everyone in your family to keep getting tested if you're seeing signs of cancer in the family. It's a good thing to do.
Thank you, Carrie. Gail?
I would say, I mean, I live by, my mantra is live one day at a time, you know, or take one day at a time, because when I got diagnosed, Elahere was not a thing. So you know, if I gave up then, I wouldn't have been here to try it now, you know? So I think that you just like need to take it one step at a time. And like you say, get all the knowledge that you can, either from your doctors or from, you know, even venues like this. You know, I joined NOCC and listened to other people's stories and was like, wow, I didn't know that about that, or, you know, I didn't have that side effect, or, you know, and there's always something to be learned by sharing with other people.
Thank you. And the three of you, we are so grateful for your honesty this evening, being so forthcoming and sharing so much about your stories. And I'd like to turn to some of the other questions that were in the chat, Dr. David-West, just to make sure that we cover them. Is there a health danger of being on Lynparza for over 2 years? And Evelyn, can you just reiterate again how long your doctor anticipates keeping you on Lynparza?
2 years.
2 years.
Yeah. Yeah, my understanding is that so I'm just like how it was studied, right? That 2 years is sort of like the max. So after June of 2025, I won't be on any kind of maintenance.
So Evelyn's correct. All the data that we have has looked at a 2-year maintenance treatment course. And so, yes, there are potential risks with Lynparza or the other PARPs. Most common are anemia or platelets being low, thrombocytopenia. Those are the two most common. And then there is a long-term complication of potential leukemia. There's about 2 to 4% risk of developing leukemia while on Lynparza. And the idea or the data says that it's longer term use of it, but there have been incidental cases where, you know, within the first year, somebody developed the leukemia. And so definitely risks to it. There are some people who are afraid to come off of it after those 2 years. And so they kind of beg and plead and can I stay on it? And some doctors are like, okay, let's kind of see how things go. But the minute, you know, blood counts start dropping or things start trending in a different direction, there's really nothing for us to hold on to that says you're going to get benefit after those 2 years. So you reach that risk benefit pendulum, right? Like it starts swinging to the more risk, less benefit. So really 2 years is the cutoff right now, and with more data, we'll have more information to see if we can extend it beyond that.
Thank you. So Carrie, were you nervous when you came off of your Lynparza at first?
Rubraca, but
Rubraca, sorry.
I don't know if I was. You know, mine was I was right at the 2-year mark. I was a little past it, and that's when I made the decision to have double mastectomy, and I had to come off of it before my surgery. So they just didn't put me back on it. And they explained to me that the current data did not show any benefit to stay on it longer. And I have to tell you, because I had to be off of it and I had the surgery, I didn't realize how there were side effects and it was affecting how I felt. And I felt better being on it. So I didn't really want to go back on it, quite frankly. But then again, if someone told me it would help me, I would have. But you know, I was fine with the decision.
Excellent. Well, thank you. And again, it's about having those open dialogues and conversations with your doctors and doing your research. And if you're not sure of the answers to the questions, ask again. So Elahere, Dr. David-West, is relatively newer for patients. Is there a time frame of being on Elahere right now? Like a suggested time frame like there is for the PARP inhibitors?
Sure. I think that's still to be determined, right? We're kind of looking at the most recent, the study that was done that approved it was until disease progression or intolerance. And so, you know, we're finding, I think it's incredible, Gail, that you had that pneumonitis and your doctors found a way to help resolve it so you could continue on the drug. And that's excellent. That's excellent teamwork. And if it's helping the disease and we can overcome the side effect, that's really the whole purpose, right? The whole point of navigating with your multidisciplinary team. So it's currently until progression or intolerance to the drug.
Okay, thank you. So at this time, I think we answered most of the questions that were in the chat. I want to thank you all for sharing your time, but I would love if the audience, if it's okay, Dr. David-West, if you have a few more moments, if we could open it up to the audience, if there is any other questions that anybody has, you could take yourself off mute and show your smiley faces. I know it's a little late in the evening, but if anybody has any other questions, please let me know. I'm going to switch my view to gallery. Any other questions tonight? I know this was a lot of information, and I certainly hope that you all learned a great deal. And I would like to say, Dr. David-West, you did a remarkable job putting this in very easily understandable terms. So we are grateful for that. And I also want to say to Carrie, Gail, and Evelyn, thank you so much for being here. And it takes a lot of courage to share such personal insight into what you're going through as you are navigating your journeys and the different challenges that you faced. And we wish you all continued health.